So next we'll be talking today is about the cholinergic drugs. So we have talked about the cholinergic transmission, where we talk about the cholinergic neurons. Then we talked about the receptors, which is the cholinereceptor. So we'll be talking today again about the cholinergic drugs. We can also call them cholinomimetic drugs, or we call them parasympathomimetic drugs. So what are these drugs? They what mimic, or they are the same thing. They have the same function of what? Acetylcholine. Naturally, our body secretes acetylcholine. But here in these people, there is not only acetylcholine. So when the body cannot release acetylcholine, or when the body have issues with secreting acetylcholine, they can mimic the action of acetylcholine. Now, you can either give them directly, or them secreting acetylcholine directly, or they inhibit acetyl or butyrylcholesterol. So they can either mimic acetylcholine directly by binding to the receptor, or they decrease the acetylcholesterol. So it's two of them. So now we can divide the cholinergic agonists, or we call them cholinergic drugs, into two. We can have the direct acting, or we can have the indirect acting. Don't forget. So I told you that they can either bind to the receptor directly and act as acetylcholine, or they can inhibit acetyl or butyrylcholesterol enzyme. So now we now say that the cholinergic drugs can be divided, or the agonists can be divided into two, which is what? The direct acting and indirect acting. So the direct acting is that the drugs mimic acetylcholine by binding to the receptor, either the muscarinic receptor or the nicotinic receptor. Now, under the direct acting, we can still now divide the direct acting based on the chemical structure into two. We have the choline esters, and we have the alkaloids. So later I'll be talking about the indirect acting. Now we have the choline esters, and we have the alkaloids. Don't forget. Now, under the choline esters, we now have 4 drugs there. Under the choline esters, we have our acetylcholine, we have methacholine, we have carbachol, and we have bethanechol. Don't forget. Now we have acetylcholine, we have methacholine, we have carbachol, and we have bethanechol. So you can know them with MacBook, MAC, then B for book. So we start with methacholine, acetylcholine, carbachol, and we have choline. Don't forget. Why the alkaloids is that they are 3. We call them MAP. Now we have the muscarinic agent, you have the Pilocarpine, and you have Arecolines. But hey, one thing you have to know, not all of them are used clinically. So we'll just focus on the ones that are used clinically. Not everything are used clinically. Now, because in the alkaloids, the only one useful agent here is the Pilocarpine. And in the choline esters, the only ones that are useful here, methacholine is also in use, but it's not very much in use. Bethacholine is in use, and acetylcholine. But carbachol has phased out, so they are not using carbachol. But we'll be talking most about them and why they are useful, and also their side effect, why we cannot use them. Some are tertiary amides, while some are quaternary amides. So quaternary amides means they don't have good CNS penetration. They cannot enter the CNS. Why the one that is tertiary amides has good CNS penetration. Don't forget. But mostly the choline esters, they do not have good CNS penetration. Most of them, they do not have good CNS penetration. The carbachol, the bethanechol, the acetylcholine, the methacholine, they do not have good CNS penetration. But the alkaloids have good CNS penetration. So if they ask you choline esters just have local action. The way they bind to the receptor they need to bind to, and they affect their change, so they don't have good CNS penetration. But the alkaloids, they have good CNS penetration, which means their side effect will involve CNS. So they have CNS disturbance, which means they'll be producing seizures, they'll be producing a lot of things we'll be talking about. So before we continue now, let us just look at the action of all these cholinergic agonists. So when they bind to different parts of the body, what will they produce? So we want to look at them one by one, because I said that they mimic the action of acetylcholine, which is the parasympathomimetic or cholinomimetic, which means their work is they have the same work with parasympathetic activity. So first of all, if you are starting now, we'll start from the head. When they act on the eyes, first of all, when they act on the eyes, what do? They causes contraction of the ciliarus muscle. So when they contract the ciliarus muscle, they causes accommodation. Don't forget. Now, when we are binding to the ciliarus muscle, which means they are binding to the M3 receptor in the eyes. So when they bind to the M3 receptor in the eyes, what happens? They produce the action of what? Accommodation. So when they now bind to the pupil, the sphincter papillae. So when they bind to the sphincter papillae, which is present in the pupil, because we have the dilator and we have the sphincter papillae. So when they bind to the sphincter papillae, they cause what? Meiosis. So they can also be used as meiotic agent to what? Cure what? Or to manage what? Glaucoma. So in the eye, they are binding to the ciliarus muscle and they are binding to the iris. So if you bind to the ciliarus muscle, they contract the ciliarus muscle. When they bind to, also they have an effect in the iris to cause what? Meiosis. Don't forget. In the brain, I told you that they are also present in the brain because the cholinergic neurons are there in order to what? Increase what? Cognition, memory, and learning in the brain. So, but it should not be too much, because when they are too much, what do they cause? They can cause seizures, they can cause tremor, they can cause a lot of things. So moving on now, after the eyes, we move down to our glands. In the same eyes, you have a lacrimal gland. So when they bind to the lacrimal gland, so where can you see the lacrimal gland? Also the M3 receptor, which you call exocrine gland. So when they bind to the M3 receptor in the what? Lacrimal glands, what do? They cause what? They increase what? Lacrimation, which means the tears will be coming out very well. So also another gland you can see is our what? Salivary gland. So when they bind to the salivary gland, what happens? They also increase salivation. So we have 3 salivary glands. You have the parotid gland, you have the submandibular gland, and you have the sublingual glands. So the nerves that innervate the parotid gland is the what? Auriculotemporal nerve. The one that innervates the submandibular and sublingual is the what? The facial nerve. So the facial nerve has the snap on the what? Submandibular ganglions, which innervates the what? Submandibular and sublingual glands. So when the action is on the submandibular, sublingual, and the parotid gland, they increase what? Salivation. But the difference is that the parotid glands make our saliva watery, while the sublingual gland make our saliva to be thick. While the mixing of the thickness and the saliva on the watery is called the what? The submandibular glands. So don't forget. Also, the what? Bronchi glands, the glands that is present in the trachea, trachobronchi glands. What happens? They also increase mucus secretion. So when they increase mucus secretion, this one helps to what? Cover the lining of the trachea and the bronchus in order for what? Good passage of what? Air, and to prevent the action of bacteria on these places. Also to the same M3 receptor, because we are looking at all the exocrine glands. So now they also bind to the gastric secretion. I told you that the gastric secretion majorly is M1 receptor, but also it can have an effect of M3 receptor. So when they bind to the receptor on the M1 receptor on the gastric gland, they allow the secretion of the HCl, pepsinogen, mucus, and the rest of them. But they do not have effect majorly, and we have not known the effect on the what? On the pancreas and the what? Intestinal gland. But also it has a little effect on those glands too, because they are local glands. So the next one also on the smooth muscle. So where they are this smooth muscle, you can also find smooth muscle. First of all, you can find smooth muscle in the bronchus. So what does it do? It allows what? Constriction of the bronchus. So when it allows constriction of the bronchus, what happens? It can be used to constrict the bronchus in order to what? Diagnose what? Asthma. Don't worry. Also, it also assists in peristalsis. Also, it also assists in peristalsis. So the smooth muscles of the GI tract. So when they contract, then what happens? It allows what? Peristalsis to occur. Allow movement of food from the mouth going to onto the absorbed in the small intestine. So it increases motility and secretion. It increases motility and secretion. Also, to the bladder, what does it do? It what? Constrict the dorsal muscle in order to allow what? Urination. Don't forget. In the bronchi, smooth muscle, and the GI tract, in the bladder, it causes all this action. Don't forget. In the blood vessels and the heart, like I say, the parasympathetic nervous system in the blood vessels and the heart is different, because only sympathetic has a good action and it activates the what? Smooth muscles of the heart and the blood vessel, but parasympathetic do not. They inhibit the smooth muscle of the blood vessels and the heart. So don't worry. So If now when it binds to the M3 receptor in the blood vessel, what does it do? It secretes what? Nitric oxide, which allows for vasodilation. So on the blood vessel, it inhibits it, it doesn't constrict. It can constrict other places, but when it comes to the blood vessel, it secretes nitric oxide, which causes vasodilation. Don't forget. So for all blood vessel, it is doing what? Secreting nitric oxide to cause vasodilation. So acetylcholine on the receptor, on M3 receptor on the blood vessel, causes what? Vasodilation. So don't forget. Now, when it binds to the M2 and M4 receptor in the heart, like I said in the beginning, it binds to the M2 or M4 receptor present in the SA nodes. So when it binds to that receptor in the SA node, what is it doing? It is increasing what? Hyperpolarization, allowing the influx of potassium. So when it causes the influx of potassium, what happens? It causes hyperpolarization, which is decreasing what? Conduction of action potential through the fibers of the heart during electrical activity. So what does it do then? It decreases the heart rate, causing bradycardia. So it's inhibiting the smooth muscles of the heart and smooth muscles of the blood vessel, causing bradycardia and also hypotension. So that can be a side effect. So when you are treating patients with cholinergic drugs, you should watch on all this stuff. So bradycardia and hypotension. And when you are having bradycardia, what happens? The stroke volume will decrease. The amount that is pumping, the ejection fraction will decrease. Also, the cardiac output, there will be no much blood pumping out. So when there's bradycardia and there's hypotension, you have to watch out. And because majorly it's also helpful to when the patient is having what tachycardia too, excessive arrhythmia. So cholinergic drugs too can be administered, because when you have tachycardia, it helps to stabilize the action of the SA node. Don't forget. Now on the nicotinic, now the nicotinic action here is that what does it do? It binds to the autonomic ganglia, like I said. So when it binds to the autonomic ganglia, what happens? It affects the same change by releasing what? Catecholamine. Catecholamine specifically to the what? To some parts, to some smooth muscle fibers, so to affect some sympathetic action here. To the skeletal muscle, I told you that it has an effect in the somatic nervous system. So when it binds to the somatic nervous system, its work is to do what? To increase contraction. So when it binds to the skeletal muscle, it binds, allows the inflow of sodium and the outflow of potassium in order to cause what? Contraction. Don't forget. We have talked about the general action of parasympathetic activity using what? Acetylcholine. So it will help us so that when we are reading the drugs and when we are studying about the drugs, it's very simple. The action here is good for all these things I've mentioned, for constriction of this, constriction of everything, but only the inhibitory place, smooth muscle of the blood vessels and the heart. So any drugs we call, some drugs are specific to one thing. So when they are specific to one thing, they have an action to that part and they inhibit the rest. So the side effect can be excessively contraction or excessively relaxation. That can be the side effect. So when you are targeting a part, you have to take note of other side effects of other parts that is mimicking the same parasympathetic activity. So we have studied the parasympathetic action and we have looked at different systems and how parasympathetic nervous system works on them. So the next thing we'll be talking about is each of the cholinergic agonists. So we divided into choline esters and alkaloids. Choline esters are synthetically derived cholinergic agonists, while alkaloids are natural cholinergic agonists. So they are gotten from plants which are alkaloids, and the ones that are synthesized specifically for a purpose are what? Choline esters. So we'll be dividing them. So I remember MacBook for choline esters, the alkaloid is MAP. So one thing we have to also know before we start dividing them is that now we should classify them into some places, so you will know, it will be much more easier for you to understand them. So first of all, we have the ones that have good CNS penetration. CNS penetration in the sense that they are tertiary amide, which means their side effect will involve the CNS. So I told you that alkaloids have good CNS penetration, specifically Arecoline and Pilocarpine. They have good CNS penetration, which means their side effect will involve the CNS, while the rest do not have good CNS or penetration. Muscarine and the rest of them do not have, while Arecoline and Pilocarpine has good CNS or penetration. So next we'll be classifying them based on their selectivity to receptor, because the first one will classify them based on their CNS penetration, who is lipophilic and which one is what? Not lipophilic. The only two that are lipophilic is Pilocarpine and Arecoline. So, and they are tertiary amide, while the rest are quaternary amide. So this one we are classifying them based on the selectivity, and which one is selective to a type of receptor. Now when you remember BMM, so BMM, don't forget, BMM is Bethanechol, Methacholine, and what, Muscarine. So these three drugs are specific to the M receptor, so they bind majorly to the muscarinic what receptor, while the rest bind to both nicotinic and muscarinic what receptor, don't forget. So based on CNS penetration, we have the tertiary amide and we have the quaternary amide. Under the tertiary amide, we have what, Pilocarpine and Arecoline. The rest do not have good CNS penetration. While you have BMM, which is Muscarine, Bethanechol, and Methacholine. So the three of them are selective to the muscarinic what receptor, while the rest do not bind to the muscarinic receptor. So they bind to both muscarinic and nicotinic receptor. Don't forget. So I want you to know this before we start talking about each drugs one after the other. So the first one we're talking here is methacholine. So we divide it into choline esters and alkaloids. Now under the choline esters is methacholine. Very easy. So methacholine is a synthetic choline esters which has low degradation by what, acetylcholinesterase, which means once it is taken, it has low degradation by acetylcholinesterase, which means it has more action. Don't forget. So acetylcholinesterase acts slowly on it, and when it acts slowly on it, it has more action. So where does it bind to? It binds to the M3 receptor. So it's specific to the M3 receptor. So when you take methacholine, what happens? It goes to the bronchial smooth muscle, it binds to the M3 receptor and causes what, bronchospasm. So what is bronchospasm? Bronchospasm is the constriction of the what, bronchial smooth muscle. So when there's constriction of the bronchial smooth muscle, what happens? It causes bronchospasm, and it is very useful in diagnosing what, asthma. So if you do not know a patient has asthma, so a patient presented with shortness of breath. So if shortness of breath and all that symptoms is what, angling towards asthma, you can confirm the test by using what, methacholine. So methacholine acts for a short time, a few minutes. So when it acts for a short time, it constricts the bronchus excessively, and what, you can use it to diagnose what, asthma. It is useful in what, bronchi provocative test. So bronchi provocative test is a test whereby you what, give methacholine, it binds to the M3 receptor and constrict the bronchial smooth muscle, so increasing the forced expiratory volume to about 20%. So if the forced expiratory volume is increased to about 20%, use it to diagnose that the patient is having what, asthma. So don't forget, remember methacholine and remember what, bronchi provocative or test used to increase the forced expiratory volume to about 20%. Are you getting me now? So the another thing, that the action we have said about the pharmacological action, so the side effect really is that when you constrict the bronchus excessively, what happens? It causes what, shortness of breath, and if it causes shortness of breath, it could affect the patient's water respiration. And also when you give it excessively, what happens? It decreases the what, heart rate, cause what, bradycardia. So the next thing also, it causes hypertension, so it reduces the heart rate, stroke volume, and arterial blood pressure. So you don't give it to patient with asthma or COPD. So when you already know the patient is having asthma or COPD, you don't need to give it to the patient. And also patient with heart block, you don't give it to the patient because it will only just stop the heart immediately. And also you don't give it to patient with what, hypotension. So if you check the blood pressure and it's a little bit reduced, you don't give it to the patient also. The next one is acetylcholine. Unlike methacholine, acetylcholine can be degraded greatly by what, acetylcholinesterase, but methacholine can be degraded slowly by acetylcholinesterase. So acetylcholine here is just a prototype of the neurotransmitter called acetylcholine, but acetylcholine can be released naturally by the body, but the acetylcholine prototype can be taken as a drug, and if it's taken as a drug, what happens? Acetylcholinesterase sees that it's the same thing with acetylcholine and breaks it down greatly. So don't forget. So now, since we know that it is different from methacholine because it can be degraded greatly by acetylcholinesterase, what happens? It binds to the normal receptor M1 to M5 receptor for the muscarinic type and the nicotinic type NN and NM receptor. So what happens? It does many stuff. It does many action, like we said earlier. Now it causes what, meiosis, it causes what, bradycardia, hypertension, increase in secretion, and what, bronchial smooth muscle. So it is rare and sometimes used in ocular surgery to induce what, meiosis. So when they give a patient what, acetylcholine, it is useful greatly in what, causing meiosis, because they use it in what, ocular surgery, but it is not really in use because of it is degraded by what, acetylcholinesterase, but most times they use it in surgery to cause what, meiosis. So when you cause meiosis, it's used mainly in ocular what, surgery. but the side effect is plenty. Are you getting me? The side effect is plenty because it can cause. So when you are using it, if you are using it to target bradycardia now, if you want to decrease the heart rate with patient with tachycardia, what happens? It can cause other parasympathetic function as the side effect. So it's used to cause meiosis. It's used to cause bradycardia. It's used to decrease the blood pressure, causing hypertension. It's used to increase what? Secretion using exocrine glands, and is used in constricting what? Smooth muscle. So acetylcholine prototype is used majorly for all the whole parasympathetic activity in which I discussed what earlier. Don't forget. But it has short half-life, less than what? 5 seconds. The half-life is very short, but even lower than what methacholine. The half-life is very short and is usually given IV. But one thing you need to know that it is degraded mainly by what? Acetylcholine so fast. So the next is carbachol, just like every other choline ester. So but carbachol specifically has what? Poor what? Acetylcholine action, which means acetylcholine acts slowly on carbachol, but it acts highly on acetylcholine prototype, and it acts what? Slowly on what? Methacholine, but it doesn't really act on what? Carbachol. So carbachol have slow what? And somehow no or slow what? Acetylcholine enzyme, which means since it has no or slow acetylcholine enzyme, what happens? Which means it acts greatly on the receptor, so its action will be more greatly than what? Methacholine and what? Acetylcholine. So when it binds to the receptor, what happens? It causes meiosis. So really, when it binds to the receptor on the sphincter papillae, so sphincter papillae is present in this pupil. So when it binds to them, what happens? It constricts the pupil. When it constricts the pupil, what happens? It also immediately also constricts the ciliarus muscle, because the ciliarus muscle is present in the eyes. It's used for what? For accommodation. So when it binds to the ciliarus muscle, it contracts the ciliarus muscle and also constricts the pupil. So when it constricts the pupil, it causes meiosis, and when it contracts the ciliarus muscle, it causes accommodation. So contracting the ciliarus muscle decreases what? Intraocular pressure. So it contracted the ciliarus muscle, increases aqueous humor outflow. Again, it contracts the ciliarus muscle, increases aqueous humor outflow, which decreases what? Intraocular what? Pressure. So what happened? So you increase the flow of what? Aqueous humor. So increasing the flow of aqueous humor allows it what? Drainage. So when you allow the drainage of aqueous humor, you are decreasing intraocular pressure. So that is why it is used as a topical agent, which is used for as eye drop in treatment of what? Glaucoma. Don't forget, it is a meiotic agent, really meiotic agent used in treating what? Glaucoma. So how is it applied? It is applied as an eye drop. So when it's applied as an eye drop, what happens? It helps you to constrict the pupil. So constricting the pupil allows for what? Drainage of what? Aqueous humor. So what does it do? It opens the trabecular network, allowing the outflow of what? Aqueous humor. So this allowing the outflow allows it what? Drainage. Don't forget. So but it's not taken orally, because orally it has poor absorption, so that's why they give it as an eye drop, so that it can what? Exert its effect fast. So which means always know that it has high resistance, and it is not acted really by what? Acetylcholine. And the side effect is great because it causes excessive meiosis, because when it causes excessive meiosis, it is not good, because it can cause headache. It can cause a decrease in vision, because when you are constricting the pupil, you are decreasing the vision. It also causes other systematic what? Cholinergic effect, like what? Diarrhea. It causes what? Decrease in heart rate, bradycardia, hypertension, and others. Aside from what? Excessive meiosis, headache, and decrease what? Vision. Don't forget. So it shouldn't be given to patients with asthma or peptic ulcer, or somebody with what? Cardiac conduction issue, especially coronary what? Insufficiency. Don't forget. So next is Bethanechol. So Bethanechol, just like every other choline ester, so we have discussed MAC, methacholine, acetylcholine, carbachol. So this is Bethanechol. So one thing you need to know about Bethanechol, it is resistant to acetylcholinesterase, which means acetylcholinesterase enzyme do not act on them. Even though it acts on them, they are resistant to them. So the acetylcholinesterase acts either slowly, or even no, it doesn't even act, and which means its action will be what? Very, very much. So since we know that it's resistant to acetylcholinesterase, just like carbachol, and that you have to know, it is a pure what? Muscarinic agonist. It's a pure muscarinic agonist, which means it binds to what? Muscarinic receptor. So when it binds to muscarinic receptor, its action will be what? Greatly, just like methacholine. So methacholine is also a pure muscarinic agonist, because what happened, it binds to the M3 receptor on the bronchial smooth muscle, same as Bethanechol. So Bethanechol also acts on the M3 receptor, but here in the bladder and in the GIT. So now, one thing you have to know, when it binds to the M3 receptor in the bladder and the GIT tract, what happens? It causes constriction. So in the bladder, it binds to the M3 receptor in the detrusor muscle. In the detrusor muscle, what happens? When it binds there, it constricts the muscle. So when it constricts the muscle, it same relaxes the ureter sphincter. So when it relaxes the ureter sphincter and it constricts the detrusor muscle, it promotes what? Urination. Don't forget. Constricting the detrusor muscle, relaxing the ureter sphincter, promotes what? Urination. Also, it binds to the smooth muscle in the GI tract. So when it binds to the smooth muscle in the GI tract, what happens? It promotes what? Peristalsis. And when you promote movement or promote peristalsis movement, what are you doing? You are increasing what? Motility and secretion, which means the food can move up to the part whereby it will be absorbed and to be excreted by the body. So therapeutically and in the clinical setting, so how can it be useful? It is useful in what? Post-operative and postpartum urinary water retention, which means patient that had surgery, maybe a general surgery, or patient that had a urinary surgery. So when it is used in this case, after the surgery, if the patient is having a postpartum or post-operative urinary retention, they give the patient Bethanechol. So giving the patient Bethanechol promote what? Urination by constricting the detrusor muscle of the bladder. So also with patients with neurogenic bladder, patient with neurogenic bladder are patients whereby the spinal maturation center is damaged. So when the spinal maturation center is damaged, what happens? They cannot urinate. So therefore, you give them Bethanechol to promote what? Urination. So also patients with non-obstructive ileus, which means patients with conditions like megacolon. Megacolon, here there is no parasympathetic activity in the GI tract. So when there's no parasympathetic activity in the GI tract, what happens? The patient cannot move food for absorption and for excretion. So also you should also have now that they are what? They are quaternary amine, which means if they are quaternary amine, which means they do not cross the what? Blood-brain barrier. So I am connecting it for you. Also, you can take Bethanechol orally or subcutaneously. So you can take it orally and subcutaneously, which means they are not hydrolyzed by what? Acetylcholine. So what is the side effect here? Don't forget. The side effect here is what? Sweating, salivation, flushing, diarrhea, because when there's excessive what? Constriction of the GIT tract, it causes diarrhea. It decreases the blood pressure by causing hypotension, and also since it's also bind to M3 receptor, it also affect the bronchial smooth muscle, causing what? Bronchial spasm. So don't forget. So you don't give it to patient with urinary or GI obstruction. So you don't give it to patient like that, because if you give it to patient with urinary or GI obstruction, you are causing what? More obstruction. So you don't give it to patient with that. You don't give it to patient with asthma, because it will cause bronchial spasm. So you don't give it to patient with peptic ulcer, because if you give it, it increase what? HCl, because don't forget it binds to M1 receptor, which causes what? Increase in what? The parietal cell producing what? HCl. So you don't give it to patient with bradycardia, because it's already the side effect is bradycardia. So you don't give it to patient with bradycardia and hypertension. And its half-life, when you give patient Bethanechol, it only lasts for 1 to 2 hours. Don't forget. So the next we'll be talking about is alkaloids. So alkaloids is the second one. The first one is called esters, which I explained, called MacBook. Don't forget MacBook, which is methacholine, acetylcholine, carbachol, and bethanechol. So this one will be picking the first one, which is muscarine, because it has a mnemonic. I gave you previously the mnemonic MAP: Muscarine, Arecoline, Pilocarpine. So the first one is muscarine. So do you know muscarine is gotten from a poisonous mushroom called what? Amatina muscaria. So when any individual take what? Amatina muscaria, when you ingest it, what happens? It causes what? Parasympathetic mimetic overstimulation, which means you have great cholinergic action. The cholinergic action will be so too much. So the cholinergic action will be overstimulated, so you will be causing various stuff, which I'll give you as a side effect. Is a mnemonic, you remember. So what happens? It binds to specifically the muscarinic water receptor. So it is solely a muscarinic agonist. So when it binds to the muscarinic receptor, which is type 1 to type 5, it binds to everything. So when it binds to them, what happens? It causes overstimulation of parasympathetic what activity. So now one thing here, it is contraindicated. It is not used in treatment, like I said. So next is Arecoline. unlike muscarine, arecoline binds to both muscarinic and nicotinic receptor. They bind to both muscarinic and nicotinic receptor, but only muscarine binds to only what muscarinic what receptor, so it's solely for muscarinic receptor from type 1 to what type 5. But this arecoline binds to both muscarinic and nicotinic what receptor. Both of them are natural alkaloids. Also, arecoline is a natural alkaloid. So what are natural alkaloids? They are derived from plants, but choline esters are derived from labs. They are made synthetically solely for a particular what purpose. Don't forget. So now, one thing you have to know that arecoline is gotten from areca nut. You call it areca nut or beta nut. The beta nut is a type of nut which means they chew it. So when they chew it, it gives you so many CNS or action, which I will be discussing later. So don't forget. So it binds to both nicotinic and muscarinic receptor. It has good CNS what penetration, and it doesn't have good. So it is not used therapeutically. So it is not even used. So I told you muscarine and arecoline is not used clinically. Don't forget. They are not used clinically. They are gotten from plants, but majorly in some research they have so majorly in some research says that they are used to treat what Alzheimer's dementia, but it is not approved by the FDA. So don't forget. So in some research they say that they are used in treating Alzheimer's dementia because of what it has good CNS what penetration. But in modern medicine it is not used. So when you take what arecoline or you take the areca nut or the beta nut, you chew it by oral absorption, what happens? It gives what we call a euphoria. You just feel a sense of happiness. It gives alertness and what dependency. So it has good dependency and tolerance, which cause you continue taking it. So it's just like all these or CNS stimulant drugs. You get it now. So when you take arecoline, what happens? You'll be feeling a sense of happiness, relaxedness, which will cause create problem to us. So and when you take it too much, there's what we call submucous what fibrosis or oral cancer. So patient or any individual are taking arecoline due to that nut. So that nut excessively can cause oral cancer or submucous what fibrosis, which means the mucous membrane of the mouth to begin to what eat up and form fibrous plaque or fibrous tissue, and that fibrous tissues can cause what pain and so many stuff in the mouth, which can also progress to forming what oral cancer. So don't forget. So the next one is that the contraindication. When is it not used? You don't give it to patients with asthma. You don't give it to patients with peptic ulcer. You don't give it to patients with epilepsy. Why? Because if it has good CNS penetration, so if you stimulate the cholinergic neurons in the brain, what happens? There will be increase in cholinergic activity in the brain, and excess cholinergic activity in the brain can cause seizures. So if you give it to patients with already epilepsy and you are also inducing seizure, what happens? It can increase intracranial pressure, and which can cause bleed. Don't forget. So, and also you don't give it to patients with a CVS issue, which is cardiovascular issue, or patient with a cardiac conduction issue. So you don't give it to patients like that. And the half-life here is about 1 to 2 hours when taken orally. Next is pilocarpine. We have talked about muscarine. We have talked about arecoline. So we are moving into pilocarpine. So pilocarpine too is also a natural alkaloid like muscarine and arecoline. So but this one is solely, it's a selective or muscarinic agonist, which means just like muscarine, it binds to M3 receptor. So M3 receptor, so you can see M3 receptor in the bronchus smooth muscle, you can see M3 receptor in the blood vessel, you can see M3 receptor in the eyes. So all this is a solely M3 receptor, unlike arecoline. Arecoline is not an M3 receptor. It's not even a muscarinic receptor agonist, so it can bind to both muscarine and nicotinic receptor. So that's why it has good good CNS penetration. Also, pilocarpine also has good CNS penetration too. So which means its action is that the side effect is that it will cause some CNS side effect if there is toxicity. Don't forget. So what happens now? So when you give a patient pilocarpine, what happens? It binds to the ciliarus muscle. It binds to the ciliarus muscle just like Carbachol too. So Carbachol, but one thing about Carbachol binds to the sphincter papillae muscle. So when you bind to the sphincter papillae muscle, you cause meiosis. You also constrict to the ciliarus muscle, causing accommodation, and excess accommodation will do what? Increase the trabecular network, align aqueous humor flow, which decrease intraocular pressure. So just like Carbachol. But this one here, Carbachol is used as a meiotic agent. It's used as a myotic agent specifically for what? Eye surgery. So sometimes it can also be used to cure what? Glaucoma. But pilocarpine is used specifically in curing what? Glaucoma, not as a myotic agent. It is used to what? Increase the flow of what? Aqueous humor. Also, you also use pilocarpine to stimulate salivation for patients with xylostomia, or patient with Sturgeon syndrome, or patient that has post-radiation that have damaged the salivary gland. So you can either have xylostomia or you can have Sturgeon syndrome. Sturgeon syndrome when there's prolonged dryness of the mouth, or when the patient is under chemotherapy and or blast radiation. So over radiation of the salivary gland will decrease its salivary secretion, and decrease in salivary secretion causes dryness of the mouth called xylostomia. Don't forget. And so I told you that it penetrates the CNS very readily. It penetrates the CNS, which means it is a tertiary amide. So now what is side effect? The same thing: salivation, lacrimation, you can bronchospasm, bradycardia, GIT cramps, which is also diarrhea. Don't forget. So you don't also give it to patients with asthma. You don't give it to patient with peptic ulcer, any heart disease, patient with what? Epilepsy, because it penetrates through the CNS. So it will give you so many CNS issues by stimulating the cholinergic side to cause what? Seizure. So you don't give it to patient with epilepsy also. So you don't even give it to patients with diarrhea, because the side effect of this is continuous constriction of the GI tract. So don't give it to patient with diarrhea. Don't give it to patient with urinary issue too. So don't forget. So when giving patient orally, it has reduced half-life. Why does it have reduced half-life? Because of the bioavailability decreases after it goes from the mouth to the what? Small intestine. So the bioavailability will reduce because of first pass what? Mechanism from the liver. So when it gets to the blood, the percentage of the drugs will have reduced. So it's good to give to the patient ocularly by a topical agent. So when you give to the patient ocularly by a topical agent, just like an eye drop, what happens? It penetrates directly to the blood, and when it gets absorbed to the arteries of the blood, what happens? It has good activities in the eyes, so it can last for about 3 to about 5 hours. So majorly 3 to 5 hours, averagely 4 hours. So that's why pilocarpine can last. So don't forget, it can be used in treatment of glaucoma and also xerostomia. Don't forget.
So we have treated the direct cholinergic agonists, where we divided them into the natural and the synthetic part, which is the alkaloids for natural and the synthetic part for cholinergic esters, where we use the mnemonic MAC book. What's MAC book? Methacholine, Acetylcholine, Carbachol and Bethanechol. YMAP are the natural occurring alkaloids, which are Muscarine, Arecoline and Pilocarpine. Later we'll see divided them based on their good CNS penetration, because those that can penetrate the CNS are tertiary amides, while those that cannot are quaternary amides. Then the tertiary amide, they are lipophilic. Example of them include, you have the pilocarpine and you have the arecoline. They can penetrate the CNS, which means they give CNS side effect. While those that cannot penetrate the CNS, apart from arecoline and pilocarpine, the rest cannot penetrate the CNS. Then we also classify them based on the receptor selectivity, where we talk about the muscarinic receptor selectivity and nicotinic receptor selectivity and the mixed receptor selectivity. Those that can bind to muscarinic receptor majorly is BMM. What is BMM? Bethanechol, muscarine and what? Methacholine. So these people can bind to only muscarinic receptor. Then the nicotine people, nicotine, pernicin, all of them can bind to only nicotine. While the rest are arecoline, pilocarpine, acetylcholine, Carbachol, the rest can only bind to both nicotinic and what? Muscarinic receptor. So we have finalized all of them. So we'll be moving to the indirect cholinergic agonists, because in this video we talked about the direct acting agent. So we'll be moving to the indirect acting agent, which are acetylcholinesterase inhibitor. So stay with me and watch the next video.